Hi everyone, I'm Dr. Windsor, and in this video lecture, I will be discussing the ins and outs of medications that affect coagulation. By the end of the first portion of this lecture, you should be able to define terms and abbreviations related to blood coagulation, as well as medications that affect coagulation. You should also be able to describe the physiology of how the body systems form a clot. In addition to that, you should know what coagulants are, as well as the two major categories of coagulants. You should also come away with a better understanding of the various hemostatic agents, their uses, side effects, contraindications, and administration routes. But wait, there is more. During the second portion of the lecture, you're going to gain a better understanding of the various types of system coagulants and anticoagulants. You should also be able to compare and contrast administration route, onset of action, and antagonists. So these shouldn't be new concepts to us. If you need a review, revisit my lecture on the basics of pharmacology. Lastly, you will learn about the purpose of parenteral and oral anticoagulants, as well as safety considerations for heparin dosing from the sterile field. All the while, I will also provide best practices for the surgical technologist in the handling and preparation of medications that affect coagulation. Are you as excited to get started as I am? Let's do this. Before we go too far, I want to discuss a few terms that we should be familiar with. First is anticoagulant. An anticoagulant is an agent that inhibits blood clotting mechanisms. Coagulants, on the other hand, are going to be those that promote, speed up, or make blood clotting possible. Hemostatic agents are those agents that enhance or accelerate blood clotting at the surgical site, and as such, they're going to help us reduce bleeding. Lastly, thrombolytics are those agents that dissolve existing blood clots. So now that we have reviewed some important terminology, we're going to turn our discussion to the physiology of clot formation. So blood naturally contains both coagulants and anticoagulants, but anticoagulants are going to be dominant, and this makes sense because for blood to continue to flow through the circulatory system, it has to be in liquid form. So keeping blood in liquid form is the default mechanism, because if the heart is pumping, blood is flowing through our circulatory system and we don't want it to clot. A clot would cause a blockage. This changes, however, when a blood vessel sustains damage. So let's say that we get a small cut, like I just got this paper cut this morning that started bleeding. And in this situation, the body's coagulation mechanisms are going to go to work to start forming a clot to prevent excessive blood loss. And thank goodness, because of this, I did not bleed to death, and I'm here sitting talking to you right now. But remember, the body's goal is to maintain homeostasis. So when it notices something awry, it's going to go to work to try to fix it. However, the body's natural mechanisms are not going to be effective against bleeding that is from larger vessels. So sometimes because of that, in surgery, we need to assist the coagulation process by using mechanical, thermal, and or chemical methods of hemostasis. Chemical hemostatic agents are coagulants that may be applied topically during surgery to stop bleeding. So we'll talk about some of those. We're also going to talk about a couple that also fall into the mechanical category. Now, if there's a problem with the natural coagulation process, systemic coagulants may be given before surgery or during surgery by the anesthesia care provider. And sometimes natural coagulation processes may be undesirable in surgery, and so systemic anticoagulants might be given. One example that comes to mind is when we are performing some type of surgery on the cardiovascular or peripheral vascular system. Heparin is an example of an anticoagulant that is often administered topically from the back table as well as by the anesthesia care provider. Individuals with a history of pulmonary embolisms or deep vein thrombosis may receive long-term anticoagulant treatment, and this can cause complications intraoperatively because these individuals have a tendency to bleed more easily. These patients might be asked to quit taking their anticoagulant medications a few days prior to their surgery. And lastly, if a blood clot, which we refer to as a thrombus, does form in a vessel, the natural anticoagulants of the body are going to try to dissolve it. However, sometimes they can't. And because of this, the patient might be administered a thrombolytic to speed up the breakdown of the clot. So now that we have a basic understanding of the differences between coagulation and anticoagulation, I want to talk about the 3 stages of clotting. So if you take a peek at figure 9.1 in your textbook, you're going to see the blood coagulation pathway. Now, the body's coagulation mechanism prevents blood loss resulting from trauma or damage to small vessels. And this process is actually something that we call a cascade. It's a cascade of events that occurs in 3 basic stages. And we're going to talk about each of these, but we'll spend the most time talking about stage 1. Now, stage 1 is where thromboplastin is formed. And another name for thromboplastin is prothrombin activator. So that's stage 1. Thromboplastin forms. Stage 2 is when thromboplastin converts prothrombin, which is actually called factor 2, to thrombin. Right, so we have thromboplastin converting prothrombin to thrombin in stage 2. And in stage 3, thrombin is going to get converted to fibrinogen, which is referred to as factor 1, to fibrin. So thrombin is going to convert fibrinogen to fibrin in stage 3. And fibrin is a meshwork of protein threads that works like a little net to capture the blood cells to form a clot. Now, stage 1, like I mentioned, is the formation of thromboplastin, and it involves 2 different mechanisms, and those are referred to as the extrinsic and intrinsic pathways. So we're going to talk about both of these pathways in a bit more detail. So as I mentioned, first stage of blood clotting involves 2 pathways. The first is extrinsic. This pathway is initiated by factors outside of the blood. It's also triggered by the formation of thromboplastin, which is factor 3. Now, the intrinsic pathway is really fast. So it is so fast that it's going to produce a clot in a matter of seconds. Now, there are 2 mechanisms, like I said, or pathways in the first stage of clotting, but both form thromboplastin. But the intrinsic pathway, which happens inside the blood, that is much more complicated and it does take a bit more time. So, again, just as a review, in stage 1, we have 2 pathways, extrinsic and intrinsic. Extrinsic is initiated by outside factors outside the blood rather, and intrinsic is going to be initiated by factors in the blood. So let's talk about the extrinsic pathway first. Let's go back to when the tissue is damaged, like when I got my paper cut today. Factors outside of the blood are going to be released, and the extrinsic pathway triggered by the formation of something called tissue thromboplastin. It's also known by factor 3 or tissue factor. So take a look at the funnel on the left side of your screen, and this is what I'm talking about here, okay? So when we have when we have the ingredients of factor 3, factor 7, and calcium, this is going to activate factor X. All right, so 3 ingredients. And did you notice that 3 and 7 add to 10? So maybe that is a way to help you remember that factor 3 and factor 7, and then we got to throw in some calcium, is going to give us factor 10. And when factor 10, so now we're kind of shifting over to the second little funnel chart on your screen. When factor 10 combines with proacelerin, which is factor 5, and we throw in some calcium, we're going to get thromboplastin. All right, so this again kind of happens in like a waterfall type process. We have factor 3, factor 7, and calcium. They come together to activate factor X, and then factor X is going to combine with factor 5, which is proacelerin, and calcium, and that is going to give us thromboplastin. So now that we have a better understanding of the extrinsic pathway, I want to talk about the intrinsic pathway. Remember, we're still talking about stage 1 in the blood clotting process. Now, the intrinsic pathway, like I said, is another option in stage 1, and it's initiated by substances inside the blood. I already said that it's more complex. It also takes several minutes for it to take effect, as opposed to the few seconds that the extrinsic pathway provides. Like the extrinsic pathway, it does involve the blood coagulation factors, the same blood coagulation factors. And so what is the process? Well, I made a little flow chart here for us to hopefully make it a little bit easier to understand. First, again, we have a damaged blood vessel, all right? The second thing that's going to happen is factor 12, which is also called Hageman factor, is going to be activated. The Hageman factor, or factor 7, is then going to activate thromboplastin antecedent, and that is abbreviated as PTA. It's also called factor 11. Now, factor 11 is going to activate plasma prothrombin component, PTC, and this is also called factor 9. All right. To further complicate things, factor 9 is going to combine with something called anti-hemophilic factor, or AHF. It is also called factor 8. And then we got to throw some calcium in there. And guess what's going to happen? We're going to activate factor 10. Now remember, factor 10 now is going to react with proacelerin, which is factor 5, and we throw in some calcium and we get thromboplastin. It's important to note that the extrinsic and intrinsic pathways come together at the activated factor 10. So, did you notice anything about calcium? You probably heard me saying it a few times. It's needed in all stages of the clotting process. Vitamin K is also going to play a vital role in coagulation. So, stage 1 of blood clotting is essentially thromboplastin formation. There are 2 pathways, intrinsic and extrinsic. Okay, now, sometimes a clot may occur in an unbroken blood vessel. So nothing was cut, nothing was severed, nothing was damaged. When this happens, this is referred to as a thrombus. Abnormal clotting is going to be referred to as thrombosis. So the thrombus may block the artery, and if that happens, it's going to reduce or inhibit the flow of blood downstream, and this can cut off the blood supply to distal to that, to the extremity or what have you. So if a thrombus forms in a vein, it can impede the flow of blood back into systemic circulation. And if a piece of the clot were to break free, this is referred to as an embolus. Now, the embolus will go skipping about through the circulatory system, and it's going to travel along until it inevitably gets wedged in a smaller vessel. And this can cause severe complications and even death. So while blood does contain an enzyme called fibrolysin that's responsible for breaking down clots naturally, like I mentioned before, sometimes the mechanism doesn't work properly. And if that's the case, the patient might need medical or surgical intervention. Surgical intervention would involve something called an embolectomy or a thrombectomy, where we actually go in and remove the clot. So now that we have a better understanding of what occurs during stage 1 of the clotting process, we're going to turn our attentions to stage 2 and 3. And put simply, in stage 2, the thromboplastin from stage 1 that we made is going to get converted to prothrombin, which is factor 2 to thrombin. All right, so thromboplastin converts prothrombin to thrombin. In stage 3, thrombin converts fibrinogen, which is factor 1, into fibrin. And this is what's going to create a clotting net like the one you see here on your screen. So the process of clotting is not as simple as I've made it sound in this lecture. And I understand that the first stage does not sound very simple. But the clotting process is like I said, often referred to as a cascade. And what this means is that the clotting process requires the right substances in the right amounts at the right time. And whenever one of these things is lacking, the cascade is going to fall apart and we're not going to have hemostasis. So next on our list to discuss is coagulants. So this is where it starts to get fun. So remember, coagulants are those drugs that promote, accelerate, or make blood coagulation possible. Hemostatics are a type of topical coagulant used almost exclusively in the surgical setting, and whereas systemic coagulants are generally used in the medical setting. Hemostatics serve as adjuncts to natural coagulation, and topical hemostatics are used most frequently, and they come in several forms, and some of those are films, powders, sponges, or solutions. And there are several different types that are available. We're going to talk about quite a few of them. So if you take a look at box 9.1 in your textbook, you're going to see a list of topical hemostatic agents. Some of those categories include absorbable gelatin, absorbable collagen sponge, microfibrillar collagen hemostat, oxidized cellulose, thrombin, miscellaneous agents that we use as hemostatics, and we are going to talk about each of these categories in a bit more detail. First on our list is absorbable gelatin. Absorbable gelatin is made from porcine skin. Remember, porcine means pig. So it's made from pig skin. These topical coagulants are typically applied with pressure to bleeding sites, and because of this, they're considered more of a mechanical hemostatic agent instead of a chemical one. Now, gelatin hemostatics take approximately 4 to 6 weeks to fully absorb, and they can be applied dry or moistened with saline. And I've even seen the gelatin sponge moistened with lubricating jelly if they're going to pack the rectum with it. So these hemostatic agents are used in a bunch of different surgical specialties, including eyes, ortho, GYN, ENT, neuro, and dental. And I've also used them in vascular cases as well. And it's important to note that absorbable gelatin is contraindicated in the presence of infection. It does come in a flowable form as well as a porous absorbent type structure. And remember, it's important to consult the package insert for detailed information and directions for the appropriate preparation and use of these flowable gelatins. So we're going to look at some examples of absorbable gelatin on the next slide. So on the top left corner, you are actually looking at gel foam. And sometimes the surgeon will want to cut it into smaller pieces, and oftentimes we will soak it in thrombin, which is a liquid hemostatic agent we'll talk about a little bit later. The bottom left is a gel foam kit. And this kit is going to contain gel foam sponge and some thrombin. And as I mentioned earlier, the gel foam would be moistened with the thrombin. Now, FlowSeal and SurgiFlow are flowable, absorbable gelatin hemostatics. And they are also available in a kit form. And there is definitely some a preparation required during, if you're in the role of the surge tech. In the middle here is an example of gel foam powder, and this is often mixed with saline to make a paste, and it's used on areas of the skin that have ulcerations. In the powder form, gel foam promotes granulation tissue. Now on the top right is SurgiFoam. And this is very similar to gel foam. On the bottom right is something called Gelita sponge. And this sponge can absorb more than 40 times its weight in blood and body fluids. And as it fills with blood, it's going to help stop the bleeding by forming a clot. And it's going to introduce something called platelet aggregation, which you will hear a few more times during this lecture. And platelet aggregation means that it's going to make the platelets clump together or stick together. So next on our list of coagulants is absorbable collagen sponge. And absorbable collagen sponge is made from purified bovine collagen. And remember, bovine means cow. So typically, the sponge is cut into a desired shape and it's going to be placed on the bleeding site. And in my experience, a lot of times the surgeon is going to want to cut it. So you're going to want to have the straight Mayo scissor or suture scissor ready for that. These hemostatic agents work again by causing platelet aggregation. And it's important to note here that collagen may reduce the bonding strength of methyl methacrylate, which is bone cement. So we don't want to use it on the bone before we place a prosthesis requiring cement fixation. Also, some collagens are not used in genitourinary or ophthalmic procedures. And we're going to look at two examples on the next slide. So two common examples of absorbable collagen sponge are Helatine, which is on the left, and Helostat, which is on the right. And as you can see, Helostat is a microfibrillar collagen hemostat, and the other is a solid sponge. If the surgeon is using any type of microfibrillar hemostatic agent, you want to make sure that the forceps that you provide or the instruments that you provide are dry so that the material does not adhere to the instrument and it will release from the instrument and stick to the tissue. These hemostatic agents typically stop bleeding in about 2 to 5 minutes. So take a look at figure 9.4 in your textbook and you're going to see a picture of Avitene microfibrillar collagen hemostat. And I have a picture on the screen for you as well. It's like that fluffy stuff that you see on the screen A microfibrillar collagen hemostatic agent comes in a couple of forms, and these include powder, sheets, and sponges. It can even be packaged in delivery devices like you see here for endoscopic use. Now, microfibrillar collagen hemostat, MCH for short, works by attracting platelets and again triggering that platelet aggregation. Access MCH has a reputation for causing adhesions, and because of that, any excess should be removed from the area. As a dry fibrous preparation, Avitine attracts platelets when applied again and triggers platelet aggregation. As far as its surgical application, it is only applied topically. And again, if it's the powdered form, we want to make sure that we are providing the surgeon with a dry hemostat because it really sticks to wet surfaces. Like the absorbable gelatin, it really doesn't have any side effects, but it's contraindicated in the presence of infection. And areas where we might use it include general surgery, autologic surgery, orthopedic, and neurosurgeries. There's another one called Instat MCH, and it's a pure source of collagen that has been derived from the bovine tendon. Now, Arista, another example, is a plant-based hemostat. It's the vegan one made from plant starch. However, Arista is contraindicated for use in neurosurgical and ophthalmic procedures. Another type of topical hemostat is oxidized cellulose. And we don't totally understand how it works, but when it's applied to bleeding surfaces, it swells and it serves as a nucleus for clotting. Now, oxidized regenerated cellulose, abbreviated ORC, is like the new and improved version. And this type of oxidized cellulose is made into a continuous fiber that can be applied to areas that are bleeding. And while the material is absorbable, manufacturers recommend that it be removed after the bleeding has stopped. ORC is commonly used in neurosurgery and otolaryngology. However, its use is contraindicated in the presence of infection. It's also available in knitted gauze strips or fiber form, and we're going to look at some of those examples on the next slide. So some examples of oxidized cellulose are surgical gauze, surgical new knit, Surgicel fibrillar, and Surgicel snow. And all of these are available in a variety of fun sizes. It's also important to note that Surgicel has antimicrobial properties, and it's fairly effective against a variety of gram-positive and gram-negative bacteria. However, ORC has a low pH, and because of this, we don't want to use it with any agent containing bovine or human thrombin. Now, top right of your screen, you will see Gelita Cell, and Gelita Cell is 100% organic and is extracted from cotton. So again, it's the vegan version of oxidized cellulose, and its absorption rate is approximately 4 weeks. And as I mentioned before, the surgeon might want to cut the material into smaller strips or even a specific shape, so be sure to have those suture scissors handy. Thrombin is next on our list of things to discuss. So thrombin is a hemostatic agent made of bovine origin. Again, remember, bovine is cow. Thrombin is an enzyme, and the way that it works is by converting fibrinogen to fibrin. And it's important to note that some individuals have developed antibodies to the bovine version, and so the FDA requires a black box warning on the label. A black box warning is the strictest and most serious type of warning that the FDA gives medication. A black box warning is meant to draw attention to a medication's serious or life-threatening side effects or risks. Now, I couldn't find an image of the black box warning label for thrombin, but I provided a similar one here that you can see for fluoroquinolones. As a result of this hypersensitivity to the bovine version, human-derived thrombin has been developed. And in your textbook on table 9.4, you'll see some hemostatic agents containing topical thrombin. And as you can see, it comes in several forms to include powders, which need to be reconstituted with IV saline, spray bottles, gel, sponge, sealant, and pads. So, thrombin is used commonly in general surgery, but only topically. I've also seen it used frequently in peripheral vascular surgery as well. And again, a lot of times we're soaking our gel foam in this thrombin. So you'll get the gel foam sponge, you'll cut it up into inch squares or however your surgeon likes it, and you're going to keep it soaking in the thrombin. We want to make sure that we use it immediately after preparation. If it sits on the back table for a while, that's okay. If we're not going to use it immediately and it's still in the vial, we want to refrigerate it and then use it immediately after reconstitution. It always comes in a powder form. This bottle that you're looking at, it will have powder in there, and typically the nurse is going to draw up some IV saline and reconstitute it before administering it to your field. And we want to ensure that we never inject thrombin. When it does get injected, or if it were to be injected into a large blood vessel, thrombin can cause significant systemic clotting, and that could result in death in some severe cases. So one thing we want to do to reduce the risk of injection is never draw up thrombin. And if we do, if that's how we're getting it to our field, we want to make sure that we do not leave it in that syringe, that we put it into some sort of medicine cup or shallow dish right away to reduce the risk of injection. And as you might have noticed, this bottle here indicates that it's 5,000 units of thrombin. So thrombin is an example of a medication that is measured in units and not in milligrams. It's also going to come in a variety of strength from 800 units to 20,000 units. And the speed of its clotting is going to depend on its concentration. So while thrombin does not have any known side effects, it is contraindicated for use on patients that have a known or documented hypersensitivity. Some examples of thrombin include thrombostat, thrombogel, thrombopad, Evithrom, Recothrom, Vitagel, Tissel, and Floseal. I couldn't find an image of Vitagel to show you, but it does deserve a shout out. Vitagel works with the patient's own plasma, which is drawn at the beginning of the procedure, and Vitagel should not be used in neurosurgery or ophthalmic procedures. Agents such as Tissel and Floseal are going to come in a kit, and they have to be prepared on the back table. Usually the kit has instructions like steps on there, so that can help you, but it might also help you to prepare by watching a couple of videos about how that is prepared on the back table. So next we're going to be discussing some miscellaneous agents that are also used as hemostatics. And next on the roster of hemostatics is bone wax. Now bone wax is made from beeswax and it's a mechanical barrier only. And the way it works is by forming a physical plug. It plugs up the holes where the bleeding is coming from. I'm wondering if any of you ever had braces as a kid or as teenagers. If they gave you wax to put on your brackets of your braces, this is the same stuff, folks. So bone wax is going to be used topically, mainly in orthopedics and neurosurgery, or where we are working on bones. All right, it's pliable, opaque, and waxy, and it is applied sparingly directly onto the bone, like I said. And one reason that we apply it sparingly is because bone wax is made of a biological substance, right? Beeswax. And because of this, it does have antigens that the body is going to see as foreign invaders. And this means that the body is going to have a reaction to the bone wax. And this has been known to cause chronic inflammation and granulomas. So we want to use it sparingly. When you get it back from the surgeon, it's probably going to look like they hardly used any at all. And while it doesn't have any known side effects, we want to avoid using it if the patient has a hypersensitivity to it, of course. So to prepare bone wax, what you're going to want to do is take it out of the package, and you'll want to knead it in your fingers until it becomes warm and soft and pliable. And then you're going to take a really small piece, you're going to roll it into a ball, and you're going to stick it on the back of a freer elevator or maybe a Pinfield elevator. And this is what you're going to pass to the surgeon, and they'll use that, to scrape a little bit of the bone wax onto the bone. Some topical hemostatics are also referenced as chemical hemostatics because they cauterize bleeding surfaces chemically. And two examples of that are tannic acid and silver nitrate. Now, tannic acid is a powder, and it's made from a plant, and it can be applied to bleeding mucous membranes to help stop capillary bleeding. So, as such, it could be combined with other agents and applied with a tonsil sponge after tonsillectomy, let's say. Silver nitrate is mixed with potassium nitrate and molded into these little applicator sticks. I think they look like matchsticks. You can see them here at the bottom right of your screen. Silver nitrate effectively removes granulation tissue or common warts. I've also seen it used in GYN procedures such as DNCs to stop bleeding of the cervix that's caused by the single-tooth tenaculum. Because silver nitrate has a caustic effect on mucous membranes, we don't want to use it in or around the eyes. They are also not sterile. All right, these silver nitrate sticks are going to come in like a little tube or some sort of package that might be kept in the cabinet in your operating room, but they are not sterile. At least I've never seen sterile ones. A third chemical hemostatic agent is Moncel solution, which might also be applied to the surface of the cervix to stop bleeding. It is a combination of ferrous sulfate, sulfuric acid, nitric acid, and water. And as I mentioned in a previous lecture on contrast media dyes and stains, we want to be extremely careful that we don't confuse the Moncel for Lugol solution. Both are very dark in color, and they are often used together during the same procedure. So if you don't remember what Lugol solution is, be sure to review that previous lecture. Systemic coagulants are another category of coagulant, and in a little nutshell, systemic coagulants replace deficiencies in the natural clotting mechanism. Deficiencies can be inherited, like hemophilia, or they can be acquired, like vitamin K deficiency. Systemic coagulants may be administered IV, intramuscular, orally, or subcutaneously, depending on the medication that is being used. And 3 types of systemic coagulants discussed in this chapter are calcium salts, vitamin K, and blood coagulation factors. So next we're going to talk about each of these in a bit more detail. Calcium is the body's most common mineral. Remember, calcium is crucial throughout the coagulation cascade, and if calcium levels fall intraoperatively, it makes sense that the patient's natural coagulation process will become less efficient. So because of that, the anesthesia care provider may give calcium salts intravenously to restore those calcium levels. It's crucial that the anesthesia care provider monitors the calcium levels if the patient is receiving a blood transfusion. And this is because the processing of the donated blood is going to strip it of its calcium. Calcium may also be administered orally or IM in the preoperative setting. And while calcium doesn't have any known side effects, patients with malignant hyperthermia should not be given calcium salts because malignant hyperthermia causes an increased calcium release from the muscles, which can further exacerbate the symptoms. Now let's talk about vitamin K. Vitamin K is a fat-soluble vitamin that promotes blood clotting by increasing prothrombin synthesis in the liver. And just as calcium is, vitamin K is integral to the clotting process. Decreased vitamin K levels are often seen in patients on oral anticoagulants, and some antibiotics also cause vitamin K deficiency. It can be given orally or subcutaneously. However, it's important to note that it could take up to 24 hours to produce a desired effect. And if we have a patient with low vitamin K and we need to do surgery immediately and it cannot be delayed, we might give the patient some fresh frozen plasma. It can be given intravenously. However, when we give vitamin K intravenously, we run the risk of anaphylaxis. And in some cases, administering vitamin K IV has led to shock and/or cardiac arrest. It is still not entirely clear why this happens. Some experts believe that it has to do with the vehicle or the liquid that it is mixed with. And when we must give vitamin K IV, we need to give it very slowly to reduce these effects. And still, it can take up to 6 hours to produce an acceptable effect. Moving on to the third and final systemic coagulant, which is blood coagulation factors. Remember all those factors we talked about, 2 and 10 and 8 and 5 and all those fun things? 2 factors that are shown here that are vital to the cascade are 8 and 9. And they are going to be administered intravenously in the medical setting. Factor 8 is typical deficiency of factor 8 is typical in patients with hemophilia A, and factor 9 is a complex of several clotting factors, and it's typically lacking in patients with hemophilia B. And these blood coagulation factors, they do not have any known side effects as far as we know, and there are no associated contraindications. So we're going to spend the remainder of this lecture learning about anticoagulants. And anticoagulants, again, are the agents that prevent or interfere with coagulation. These drugs help to prevent clots from forming. although they will not dissolve clots that are already formed. So it's preventative. Anticoagulants are administered to prevent thrombosis, especially those in the lower extremities, which we refer to as deep vein thromboses or DVTs. We also use anticoagulants to prevent pulmonary embolisms or coronary occlusions. Remember, these are the vessels that supply the heart muscle with the much needed oxygen and nutrients so that the heart muscle can work properly. Anticoagulants may be given after a heart attack or a stroke. They're also used in surgery to help prevent clot formation as a response to trauma or manipulation of blood vessels. Patients that are on anticoagulants, they're going to need to be closely monitored for signs of hemorrhage. And signs of minor hemorrhage might present as bruising, nosebleeds, blood in the urine, or blood in the stool. Parenteral anticoagulants. Remember, parenteral means not by mouth, any other route but mouth, right? So these anticoagulants are those that are administered either intravenously, subcutaneously, or topically. And as I mentioned previously, they interfere with blood coagulation. Heparin sodium or heparin is the most commonly used parenteral anticoagulant in surgery. Now, heparin is derived from the intestinal mucosa of pigs, and it works at several points in the clotting cascade. And the way that it works is that it inhibits factor X. Remember factor X, which is factor 10, right? And it inactivates thrombin, and this is going to prevent the conversion of fibrinogen to fibrin, thus preventing clotting, right? So heparin is also going to interfere with platelet aggregation as well as the formation of a stable clot. Some other interesting tidbits about heparin. It binds non-specifically to plasma proteins, which may be the reason why there's a variation of effects among patients. Also, it's metabolized in the liver by an enzyme called heparinase. It does not cross the placental barrier, but it hasn't really been adequately studied in pregnant women. So because of that, it should only be used if the benefits outweigh the risks. And the last little interesting tidbit is that the effects of heparin can be reversed by administering 1 gram of protamine sulfate for every 100 units of heparin that was given. And the time also makes a difference factoring in there as well. But anesthesia care provider will be figuring out all that fun stuff. Heparin is typically used in all vascular and cardiac surgeries. And as you might have noticed, heparin is another medication that is measured in units and not in milligrams. So can you determine the strength of the heparin that you see here on your screen? This bottle happens to be 1,000 units of heparin. And the strength of heparin does vary from 10 units to 40,000 units, and it has a very rapid onset of 5 minutes, and it typically lasts anywhere from 2 to 4 hours. Now, heparin is something that we may be drawing up into a syringe. You definitely want to make sure that it's labeled correctly, and we'll talk more about that in a bit. Adverse reactions associated with heparin can include the increased risk of hemorrhage and thrombocytopenia, or decrease in platelets. That's what thrombocytopenia is. So heparin is contraindicated in patients with existing severe thrombocytopenia. as I mentioned, heparin does come in a variety of strengths. You can see a variety of them on the image that I provided from you. It looks like 500 units, 10,000 units, 30,000, 50,000, 10,000. And the vials, you know, the 50,000 units one is a lot smaller than the one that is 30,000 units. So you can't go by the size of the bottle. You have to go by the label. This means that it's possible to administer the same volume of heparin, but give a dose that is far stronger than what was ordered. And for this reason, like I said, all the medications on the back table must be labeled and their strengths need to be clearly identified. So, although heparin was discussed earlier, it's important to re-emphasize some important information about dosing from the sterile back table. Many dosing errors have occurred because 1 ml of heparin can contain significantly different units, from 10 to 10,000 units. That's a huge difference. So careful attention must be paid to identifying the correct strength of heparin. 1 ml of heparin can contain 10 units, 100 units, 1,000, 5,000, or even 10,000 units. So it's worth mentioning again that it's possible to administer the same volume of heparin, yet give a dose 1,000 times more than ordered. So please be sure to always verify the number of units of heparin placed in solution for irrigation as well as the volume. And please, not that we have trust issues, but don't trust somebody to just verbally tell you what it was. Make sure that you get your eyeballs on that label. Your patient's safety depends on it. So, again, I know I'm on my soapbox here, but it can't be stressed enough how important it is to use general medication safety rules and exercise the utmost caution to verify the actual dose of heparin. Be sure to repeat the solution strength to the surgeon when you pass the medication. For example, I have 5,000 units of heparin and 1,000 mLs of saline, right? A lot of times we are diluting the heparin with saline. We're drawing it up into a syringe. With cardiovascular cases, you may have 5, 7, 10 different medications on your field in med cups and syringes, and they're all clear and they all look the same. And without really careful labeling, you could accidentally cause your patient to be injected with something that they were not supposed to be injected with, and that could ultimately lead to the death of your patient. So getting off my soapbox about heparin, let's talk a little bit about low molecular weight heparins, or LMWHSs. Low molecular weight heparins have the same uses as regular heparin, or we call that unfractionated. And they also work in the same manner, but the difference is low molecular weight heparins can be used outside of the hospital setting because patients and their caregivers can be taught to administer the drug subcutaneously. They also differ from unfractionated ones in that their effects cannot be reversed with the administration of protamine. And some examples of low molecular weight heparins include Fragmin, Inohep, and Lovenox. Enoxaparin is the most commonly used to prevent postoperative DVTs following abdominal surgery, hip, or knee replacements. It's typically administered subcutaneously, and it has medical uses, not surgical ones. It also should not be given with other anticoagulants like aspirin. All right. Side effects do include local irritation, pain at the injection site, sometimes fever, and nausea. I can't help feeling like I sound like a TV commercial right now. Factor XA inhibitor, also named fondaparinux sodium or Erextra, is only for subcutaneous administration, and the medication is typically used to treat post-operative and long-term prophylaxis of DVTs and PEs, deep vein thromboses, and pulmonary embolisms in orthopedic, total joint, and abdominal surgery patients. It has an identical structure to heparin. However, it's administered no sooner than 6 to 8 hours post-operatively, and it's crucial that we don't confuse it with Arista, which is a topical hemostatic agent. There are also oral factor XA inhibitors like Xarelto and Eliquis. Another category of anticoagulants is oral anticoagulants. Oral anticoagulants are used for long-term management of thromboembolic disease, and that does include DVTs and PEs. And because they have a delayed onset, they're contraindicated for use in emergency type situations. Warfarin is a derivative of Coumadin, and it is a widely prescribed oral anticoagulant. It is a highly bound drug. So it is highly bound to plasma proteins, and it is also metabolized in the liver. And if you're unfamiliar with the concept of plasma protein binding, be sure to review my lecture on basic pharmacology. The onset of warfarin is approximately 2 days, and its duration is 2.5 to 5 days after it has been discontinued. Its effectiveness needs to be monitored, and the way it is monitored is by using something called a prothrombin time test. Warfarin is also known to interact with a variety of substances, and because of that, all other medications are going to need to be closely monitored. In addition to that, we do not want to take aspirin when we are taking warfarin. And lastly, some side effects can include epistaxis, hematuria, and bleeding gums. Aspirin, also called acetylsalicylic acid, is another oral anticoagulant. We've probably all heard of aspirin. Aspirin prevents clot formation by inhibiting platelet aggregation, and it may be given after a heart attack or reoccurrent ischemic attack to reduce the risk of further incidences. Just 300 milligrams of aspirin can double the normal bleeding time for up to 7 days. So remember, it's going to be contraindicated with concurrent Coumadin or warfarin use. And there are some alternatives to aspirin, and these include Persantine and Plavix. Lastly on our list of things to discuss are our friends, the thrombolytics. And table 9.6 lists generic and trade names for various thrombolytics. Some of them include streptokinase, urokinase, alteplase tissue plasminogen activator, also called activase, and one called T-in-case. So the purpose of thrombolytics is to help dissolve blood clots. So they're often used to treat acute myocardial infarctions when coronary thrombosis is present, and they may also be used in conjunction with anticoagulant therapy. Now, alteplase or activase is a thrombolytic agent that is produced by recombinant DNA technology, and this is a second-generation thrombolytic. Second-generation thrombolytics are produced by recombinant DNA technology, and they are biosynthetic, and they're made from a naturally occurring enzyme called human tissue plasminogen activator, or human TPA. And this is extracted from ovarian cells of the Chinese hamster. And common uses include acute MI with coronary artery thrombosis and treatment of DVTs, PEs, and CVAs, which are cerebral vascular accidents. Because alteplase is a human enzyme, fewer allergic and hypersensitivity reactions occur, which is a good thing. Another advantage is that it acts specifically targeting clots rather than exerting systemic effects. So that wraps up our discussion regarding medications that affect coagulation. And I hope this provided you with a better understanding of how these medications work, as well as the considerations associated with the role of the surgical technologist regarding the handling and preparation of coagulants and anticoagulants. So until next time, keep being the amazing, aspiring surgical technologist that I know you are. Take care.